Okay. Let's get on. Hi, I greet everyone. It's a wonderful day. I mean, my excitement comes when it's time to teach, right? It's just time to teach. I love it. I love to do this teaching thing. So if you are alerted this evening that your doctor is live now, make sure you join the live and let's come together and then study something very interesting, very important. So over the weeks we've been talking about endometriosis. So I would wish that most of you will come so that you join the live on the other side. But if you are still here, then it means you really want to know, but um, not want to support. Anyway, if you join us on the YouTube, kindly take a second, subscribe to our channel, join us whilst we are here, and let's enjoy together. Let's go on. So over the period when I kept on talking about endometriosis, people kept typing, or they were consistent about the fact that we need to speak about adenomyosis, which is very, very true. It goes hand in hand. It's one of the topics that is like, anytime you want to talk about, let's say, football, anytime you want to talk about Barcelona, you need to bring Real Madrid in to make the competition or to make the conversation very interesting. So it's the same way we have adenomyosis and endometriosis. So there's a difference. Last time I mentioned that endometriosis has to do with the endometrial tissues that travels all the way to the surrounding or the pelvic area. Okay, apart from the pelvic area, it's able to spread to way different places. Okay, to different places like the ovaries, the ligaments that support the uterus, the liver, the peritoneum. It can go as far as even the lungs. And over there, you can tell that is causing a lot of inflammatory issues. And in the same way, it's causing some other issues with estrogen production, infertility, excessive pain, excruciating pain, either during sex, during menstruation, and all that. Now, the thing about adenomyosis carries a similar trajectory, but I'll be explaining a lot more into adenomyosis. I've not made any video about adenomyosis yet. I want us to get the clear understanding, and then after which, you know how we do it. The videos are going to pop up, step by step. So let's get into the topic. All right. So when we say adenomyosis, okay, when we say adenomyosis, I want to switch an account to be able to see what is actually happening on the other side. When we say adenomyosis, okay, we are talking about the other side. We are talking about the now I can have a clear view of how things are happening on the other side, so that it doesn't look like I'm shooting differently. Yes, good. Pardon me, guys. I'm trying to be a technical guy, as at the same time be a medical doctor. So it's a benign condition. Anytime we say something is benign condition, it means that it's the condition is localized. Okay, it is localized. So this should inform you and I that I'm going to only or specifically speak about the uterus. That is the main organ that is responsible for carrying a baby. So every woman on this live now, if you're a woman and you're on the live, it means you have a uterus. There are some people, they don't have uteruses. But there is one thing. I don't know, those who were able to listen to our brother Wodemaya, he was talking about how the the uterus of the partner was in different forms. So I took a lot of information from his interview with Bolare, and I will be coming on live, or I'll be coming out to explain to people the different types of uteruses that exist in women. There are some that are biconate. There are some that the uterus has caved in. There are some that you can have a child growing on one side, and because the uterus have caved in, it's preventing the growth of the child on the other side. All right. So there are different types, which I'm happy to come and teach on that. I'm happy to come and lecture people on the types of uteruses and etc. That will be coming soon. So if you've not followed yet, if you've not subscribed yet, kindly make it a point to subscribe to the channel and join us on the things we do over here. It's preventive medicine we are teaching. All right. So when I say it's a benign condition, I'm trying to say that it has to deal with just the uterus. Okay. Just the uterus. Everything we are going to talk about is the uterus, and we women, or the women on the live here, you understand that the uterus is where the baby goes to lie. Okay, that is the same place you get the fibroids, you get the endometriosis. We keep on saying that when you are having your menses, the blood flow from there is release of egg and etc., and then the blood washes the endometrial lining, and then it comes out. Right? It comes out. So it's a benign condition that has to do with the endometrial glands. Okay. We call them glands. Now, these glands and stroma, they are glands and stroma. It's like you have something like, as we are all here, all right? As we are here, we have organs in us, right? So let's say that this is our body, but the organs in us are glands and stromas. They make up the formation of the uterus. Okay, so we have glands and stromas that are found within the uterine muscles. Okay, they are found in the uterine muscles. Now, these muscles are called the myometrium. The muscle of the uterus is called the myometrium. Now, they cause diffuse or focal thickening of the uterus, and often they cause heavy, painful menstrual periods. Are you getting it? Cheers, senior. I greet everyone. I salute everyone. If you are joining for the first time, we are live here and we are live on the other side as well. I think you guys know, on the YouTube. Yeah, it commonly affects women in their later reproductive years. Now, let me explain later reproductive years to you. Now, so if you see a child or a woman who is in the ages of, let's say, 13, 14, 15, all the way to, let's say, about 22, you are in your early reproductive years. You are in your early reproductive years. Now, when we talk about late reproductive years, that is when you don't know, or this condition is never there. Okay, but progression, that is why it happens in your later reproductive years. Progression, as you are growing, you are getting there. It's like you are 22, 24, 26, 28, 30. Okay, you are getting into an aspect of your life where a lot is going on. You are trying to make babies. You are trying to actually settle. You want, a lot of things are happening in your system. All right, a lot of things are happening. Hormones are being secreted. Several other chemicals, neurochemicals like the cortisol, the dopamine, serotonin, a whole lot of things are being secreted in your system. So now, during this phase or during this stage, there is the sudden growth of some of these chemicals in your system. Now, the strand and the stromas tend to, grow excessively. So you can tell there's it's even clear here that in later reproductive years and frequent, they coexist with fibroids and endometriosis. What did I tell you guys? What did I tell you? I told you that there is this same uterus that happens to cause fibroid production or cause the occurrence of fibroids is this same uterus that also you are menstruating. So whilst you are menstruating, what is happening? There is constant secretion or rubbing of the endometrial lining, and these are able to cause the strands and the stromas to form and then begin to deposit on the uterus. Now, we can say that what are some of the causes, and then we can move on. Salute. What are some of the causes? So the exact cause is unclear. Now, most of these medical conditions, the causes are unknown. The causes are unknown. So usually the way the disease occurs is how it helps us to actually be able to help in treating. I hope we are getting the point I'm raising here. It's a bit difficult, but that is what happens. Now, let's talk about it. Tissue injury. Do you realize? Let me talk about this part. Example of a tissue injury is, have you been pregnant? Yeah, let's go there. Let's go there. Have you been pregnant? Lost your pregnancy, and then they have to do what we call a manual vacuum aspiration. Manual vacuum aspiration. Now, this is the procedure where we put a tube, like a thin tube. We go in, and while suctioning, okay, we are suctioning the uterus. We are suctioning to see if we can pick any uterine of any body of the fetus, okay, the fetal part. We are trying to suction it out. Now, this can cause uterine injury. Okay, by the time you are done, that is why sometimes your doctors will put you on some antibiotics, some medications, because you'll be bleeding. Okay, that's an injury. So you'll be bleeding, and then they will try to stop the bleed. They will also try to give you some antibiotic because they might have caused an injury to the uterine wall. And if this is not done, okay, if this is not done, those who have had spontaneous abortion, that the complete fetal parts did not come out, during this time, they are going to do some of these things, the manual vacuum aspiration, to try to bring the entire fetal parts out of your body system. Okay, out of your body system. So that is what we call the invasion theory. Now, in this invasion theory, during this process, okay, those who are thinking penetration, that's not what I'm talking about. Very, very bad boys and girls. So this process is a means of inoculating. Okay, it's a means of inoculating the endometrial tissues, that is the stroma and the glands, into the specific areas of the uterus. Into the specific areas of the uterus. And when this occurs, it's going to leave the deposition on the walls of the uterus. Do you understand? So they gave some example. They said the disruption of endometrial myometrial junction. So the part, okay, let me be clear on this. The part where there is deposit of endometrium, so the junction, when we talk about the junction, it's where the endometrium, I wish I had something here to be showing you guys, where the endometrium is the inner part of your uterus. Okay, the inner part of the uterus. So from the inner part, we go to the middle part and then the outer part. Now, the junction between the inner and the middle part is where, when you constantly penetrate, you are inoculating directly into these areas, and it becomes a very, very big problem. So example is during vaginal delivery, during pregnancy. So immediately I said vaginal delivery, someone says, hey, Yes, during vaginal delivery, I'll explain to you. Imagine, imagine you are actually delivering a baby using the forceps. Let's say the head of the baby is stacked to the shoulder. We call it shoulder dystocia. So the one side of the shoulder is stacked. So you are going to manipulate. You are going to cause manipulation. You need to turn. We call them maneuvers. You need to cause maneuvers in order to turn the baby and then be able to bring the head of the baby out. Now, during this process, there is actual trauma to the uterine wall. Another one is, it's not just the trauma. Do you remember that it gets to a part, the head is stacked just up to this part? It's stacked, and sometimes we need to cut or make an incision in these areas down there. You make the incision, you introduce or you cause trauma to the site. Do you remember that when you are bringing the placenta, the cord, when you hold the cord and then you wrap it around, okay, let's say that is the placenta. The placenta is at the back. That's the placenta. And then when you are pulling, you need to bring the whole thing out. So you are going to wrap so that you have a firm grip to pull the placenta out. Now, during this process, what is happening? You are causing trauma to the uterus. That's the uterine lining. You are causing trauma to it. And during this process, it's going to cause a lot of bleeding, pain. Mucus will move from here to here. The placenta is going to... Do you get the concept I'm trying to paint here? So during delivery, during pregnancy, vaginal delivery in itself, cesarean section, let's come there. Let's come to cesarean section. Now, in cesarean section, what happens? So we make an incision on the lower. It's not all the time that we make the incision on the lower part. There are cesarean sections that we have to go transverse. Okay, so let's say we've made an incision down there. We make a cut. Now, this cut, we need to bring the uterus out where the baby is. We need to try to deliver the head of the baby. So let me show you the steps. Okay, you clean, you make the incision, a phalangeal incision or which type of incision you are going to use. You make an incision. You make the incision, the skin is what you've incised. Now you need to separate the fat tissues. You separate it, you get to the muscles, you separate the muscles. Now you see face to face, you are seeing now face to face the uterus where the baby is sleeping. So you need to make another cut so that you can get access to the baby's head or the baby in the uterus. Right. Now that you are there, you hold and bring the baby's head out. Whilst you are bringing the baby's head out, don't forget that the placenta is attached to the uterus. One, the baby was lying in a buoyant sac, which is attached again to the uterus. It contains fluids, okay, which was feeding the baby. Now, at this point, we need to burst the sac and bring the baby out. Baby is coming out. Whilst baby is moving out, there is one thing that, sorry. The baby is going to detach from the wall of the endometrius. Where does the detachment, the things that it's like you are building, the cement that you've used to build the entire building, the cement that is causing the blocks to lay on each other, that cement, when you take one block off it, what is left for the cement? You can tell that you don't get the actual smoothness of the cement anymore. So there are parts that are going to tear off. That is why when the placenta comes out, the doctors are like this. Let me show you. This is what the doctors do. I'm telling you what happens in the theater. They will take the placenta from one point to the other to make sure that every single part of the placenta is intact. So even in our notes, we type that placenta intact. You have to type it. So they take the placenta from one side to the other, they hold from the cord angle and then begin to move. I hope I'm not wasting your time. If they get to this part and they see that, oh, this part is detached, there's a tiny part of it, they need to put the gauze and go in clean and stuff like that. When the membranes, thank you, when the membranes are attached to the wall of the uterus and they forcibly take it out, this is going to transfer some of the stroma and glands to the endometrial tissues. So adenomyosis, that is the first theory that we realized that it was causing adenomyosis. Endometrial ablation, curettage. I mentioned curettage already, isn't it? Yes, I talked about when we have to do manual evacuation, okay, and we are doing that thing. It's called dilatation and curettage, DNC. I know you've heard of DNC several times. Yes, that's what I'm talking about. So that is the first theory that came up. Now we call something metaplasia. Now, what is metaplasia? It's not just the term metaplasia. We are talking about the Mullerian remnants. Mullerian remnants are actually, during the menstruation, there is release of egg, there is it has to come and mix with blood, and then this whole process will then wash out as part of menstruation. Right. Now, this is a Mullerian remnant. Now, the remnants are, let's say you've menstruated, but still, that's why some people are able to come out to say that, oh, I still get some filthy fluid that comes out from the, after my menses and etc. I tend to get some of these filthy, fluid is dirty, it looks horrible and stuff like, people tend to come up with some of these words, right? Yes, so these are some of the remnants or their stem or progenital cells, which they are within the myometrium and the endometrium, which then tends to stick inside the uterus. And in so doing, it begins to cause or propagate the growth of the stroma and the gland cells. If you understand, give me a like, give me a shout. I've not seen any reaction from you people. It means that what I'm saying is not really it's not good for you. If it's not good for you, let me understand so that we move on or we change the topic. All right. Let's continue. There are things we call hormonal factors. So someone is asking in my comment section, someone is answering. Okay, will cause bleeding continuously and may. All right. Thank you for the support you are giving me in the comment section. Some of them I can't really see because I'm trying to, read from two angles. All right. So let's go on. We have hormonal factors, and this is where the relationship between the endometriosis and the adenomyosis falls in. The relationship. Okay, the relationship. So you are going to listen to me carefully over here. You see, I told you when we were doing the endometriosis, or you can check the other live on this podcast. You can check and you would understand that I earlier on mentioned that endometrial tissues are constantly being fed, or they are constantly being supplied with estrogen. Now, the estrogen has the ability to cause growth of the endometrial tissues. What makes up the endometrial tissue? Stroma and glands. What did I say was adenomyosis? Stroma and glands. Are you getting the picture? Stroma and glands are the components of adenomyosis. And these same components in adenomyosis, we call them the endometrial tissues. Right? The endometrial tissues. Now, these tissues are being fed by what? Estrogen. So in other words, estrogen dependent disease. That's how we can call it. It is an estrogen dependent disease. And it's going to happen late in your reproductive years. When it's late, when we started, I mentioned that late reproductive ages are those ages after 24, 25, 26. During that time, you are on the rise. There is release of cortisol, there's release of estrogen, progesterone, there is serotonin, dopamine. Your entire system is just like you are there. That is how come we will see female characteristic features on you. You are like, my boobs are, there. My bum is, my shape is like that Fanta Coca-Cola bottle shape, and you use all those. How do we call it? You use all those criterias for yourself. Now, during this point, during this stage, you are growing. You are actually getting there. Your productivity is very, very high. And this is the same time you are going to have the stroma and glands of the endometrial layer progressing. So it begins to grow just randomly, just anyhow. So if you are not careful, you didn't have any issues during your youthful times. Let's say when you were 18, when you were 20, you can tell that, I didn't have any of these problems. Where is this thing coming from? That is the point you get worried. You get worried about what is happening to your life. You get so worried, especially when you start to make babies. Some people, or in majority of people, the first time they got to know there is a problem was when they tried with their partners. Some of them, they went on honeymoon after wedding and etc. They went for honeymoon and stuff like that, and they've had consistent sex for months and there is no pregnancy. And they begin to ask themselves questions. What is happening to me? They begin to ask questions. What is actually happening to me? In this instance, you should know there might be an issue with your hormones. There might be an issue with the anatomical structure, which is the uterus. There might be a problem with the fallopian tube that has to carry the egg all the way into it and begin to produce. There might be a problem. You need to find out the cause. What is leading to that? What is leading to that? And that is why we are here doing some of these teachings. So, looking at hormonal issues. Let me come this way. Looking at the hormonal issue is estrogen dependent. Please bear in mind, whenever you go to the hospital, they start telling you that there is estrogen issue. Please bear in mind, there are things that depends on estrogen. Please let the doctors do the hormonal balance test. Let them do the hormonal test so that it will be able to help you know or pick up what is actually happening to you as an individual. So someone is saying, okay, African is saying that sometimes is the man's problem for not getting pregnant, doc. Yes. So what I'm saying is, I'm talking about the woman now. Okay, African, I'm talking about the woman now because adenomyosis affects the woman. So when these things have been detected in you as an individual, make sure that some of the searches may come out. You see, when it comes to the men, we'll be doing a whole month on men's health. Okay, so don't worry about it. I'm not putting any blame on any woman for not being pregnant or anything. No, I'm saying that some of the causes you need to request so that they may go further in picking up some of the causes that might be affecting you as an individual. Okay, so let's go on. high parity associated. Do you know high parity? Do you know high parity? High parity. So in other words, they weren't even supposed to say high parity. They are supposed to use words like primary gravid is someone who has actually given birth. That's is giving birth for the first time. Now multi-gravid, okay, or when they said high parity, it's just telling us they have more than one child, more than two children. They have actually delivered, or they have children up to a particular number. Now, in this instance, do you remember we talked about pregnancy as one of the factors that causes endometrial tissue? It's like you are putting the adenomyosis tissues, the stroma and the glands, you are actually putting it in there. You are inoculating it in the person's system, in the child, in the woman's system, right? So that is the high parity is high number of children. Now let's go. There are people with genetic history, especially first generation. If you have a mom, so let's say you who is listening to me right now, you have adenomyosis. You have adenomyosis. Let me try to draw and see. You have adenomyosis. Let's say your mother had adenomyosis or endometriosis. It is not automatic, but the probability that you may transfer this issue to your children is very high. If you've not, someone is saying they are going to ask a question, and I'm going to say something. If you don't follow me and you ask a question, I'll look at your question like this. You have to follow me, and you have to subscribe to my channel as well, and then I'll be answering your questions. Anyway, you can ask your question as we go on. Okay, so if you have any questions, you can drop them in the live chat. I should be able to see them and answer your questions right here, right on time. So I think currently those who are asking the questions are people from TikTok. Otherwise, YouTube, they haven't asked me any questions yet. Yeah. All right. Let's proceed. I'm here because I'm also monitoring the video. I'm also monitoring it. Okay. So there is something we call familial clustering reported. So that's one of the examples I gave you. Let's say your mom. So you yourself, you're at risk. Let's say when you started seeing your menses, your mom told you that, oh, for her, it was really, really tough. It was, going through her menstrual period was really, really difficult. It was painful. It was this, it was that, it was that. So in this case, what is happening? She's communicating something to you. I was going to ask that question about familial link, but you've answered it. Okay, so if you have a first gen, when I say first gen, and that is the very, very dangerous thing. Most of us, our parents have several conditions and other things that we are supposed to pay attention to them, but we don't. Okay, you can see that your mom is going through, let's say, diabetes. She's living with diabetes. Your dad is living with this condition and stuff like that, but we don't pay attention to them. Now, in this situation, in most of the first generation medical condition, please be mindful. Please be careful. Please take care of yourself adequately. Because in the first generation, you actually have direct access to familial history. Now, let me show you something. The genetics are the things that your mom and your dad came together to give you, or they brought together to form you. Now, let me tell you something about familial. When it comes to familial issues, it has to do with environmental factors. Please pay attention carefully. It has to do majority with environmental factors. In the morning, your mother eats this food. Your father eats the same food. The entire family eats this food, which means that if there is any form of side effect or toxicity, all of you are going to share it equally, right? You live in a house where your father is constantly smoking. Your mother is constantly drinking alcohol or also smoking. Now, in a home like this, what is going to happen is the child hasn't hasn't given the permission to any of these parties to transfer some of these things to the child. But by means of association, the child is going to become a tertiary smoker or a secondary smoker, and the mother's alcoholism and stuff like that, if she's breastfeeding, is going to be a means of transfer into this child. So some of these issues tend to come up. Okay, so mostly familial history. Bear in mind, because it's one of the things that a lot of people think, you need to have this before that. No. Some of them, it has to do with environmental situations. Let's go on. So when we talk about the genetics, I've mentioned familial. There is also what we call local inflammatory and immune dysregulation around the endometrial. That has to do with genetics. Okay, that has to do purely with genetics. Now, at what age does this adenomyosis, okay, so if anyone comes back to say that, Doc, you need to speak about adenomyosis, tell them that we have streamed it. It's on our tube. They should go and have access to it. All right, good. So let's talk about the age range. This will surprise you. From 30 to 50 years. 30 to 50 years. Who would have thought that a 50-year-old woman can get adenomyosis? I told you that the later part or the latter part of your puberty times, up to 50 years, you may get this medical condition. Now, the history of uterine, if you've had CS before, if you've had anything like any uterine surgery, like endometriosis, you've had endometriosis before, you've also had maybe fibroid removal before and all that, it can happen. Can it occur in menopause? That is the point where the estrogen levels, so guys, listen, the estrogen levels are dipping. And I told you that what? Estrogen, these cells are estrogen dependent. These cells are estrogen dependent. And so now that it's dipping down or it's coming down, you don't need to actually be scared when you are in your menopausal stages. In your menopause, you don't need to fear, because most of the estrogens have gone down. And so the thing that has to feed these tissues are no more. The hormone or the water that has to feed the tissue is no more. I hope we are getting the whole point. Yes, so that is it. Now, how does this whole disease, occur? We've talked about some of the causes. We've talked about some of the risk factors as well. Let's see. So endometrial tissue embed in the myometrium. This is what I usually want people to understand, because if you understand the pathophysiology, if you understand how the disease occurs, you understand how to treat most of these things. So look at this. The endometrial tissue embed in the myometrium. I told you that the endometrial tissue is the inner part of the cervix. Okay, so in my mouth, like this part is the endometrium. This part is the endometrium. Now, between this part and the back here, my skin, there is some muscle in between. Now, the muscle in between is called the myometrium. The myometrium. So we have endometrium, myometrium, and then what is here? The skin. Now, between this part, these endometrial tissues, they embed in the myometrium. It's like when I punch my lips, what will happen? Boom! What is going to happen is the endometrium is going to end up entering into the myometrium. Okay, just like you see someone has, when people are fighting and you see someone has given the other party a punch, there is going to be transfer of the tissues or transfer of the part that has been touched that goes inside and cause damage to the inside part. So that is what is going to happen to me. Punch, boom. The outer skin will enter into the middle one. And if the punch is very severe, it can enter into the third part. The same way, if I punch this part, it's going to cut through. Right? So endometrial tissue is embedded in the myometrium, remains hormonally responsive. Now, it has gone in. I told you that it relies solely on hormones. Still, the hormones are working. The hormones are producing. The hormones are functional. In this case, we have this outer part or this inner part that has transferred into the inner layer. And in the inner layer, it is still functional. It's not spoiled. It's not damaged. It's not spoiled. It's not damaged. So the cells are still functional. It's still working. So over there, in there, the tissues will be secreting the estrogen. The tissues will be causing the growth of these cells. But in this instance, it's telling us that you are a foreign body in a different part of the body. You are a foreign body. The stroma and the glands will continue to grow. You are a foreign body. And this foreign body will keep on growing. They break down and they bleed with each cycle because it's dependent on what? Estrogen. Do you understand? It's controlled by estrogen. We call something this ectopic tissue. Now, ectopic means it's occurring on a different site, and that is what has occurred. That is what has occurred. Boom. Inner part cuts through outer part, and the inner part continue to stay in the outer part, and because it still has hormones or stroma and glands, it's still depending on the estrogen. It's not spoiled. It's not condemned. It still keeps on growing and growing and growing, and this becomes very, very toxic to the part. It's just like a tissue that has entered into your nose. It's not supposed to be in your nose. How do you feel? All the time you just try to blow your nose and stuff like that because the discomfort around is irritating. That is what the adenomyosis is. Now, thank you guys. That is the catch. It is going to cause irritation over there because it is a foreign body in the specific area. It's not supposed to be in that area. So immediately it gets into that area, it begins to cause irritation. I don't like here. I don't want to be here. You are worrying me. I don't want to see you over here and stuff like that. And that is it. Good. So it's going to trigger I'm so excited I was able to explain that part of irritation to you. So this is going to cause the smooth muscle hypertrophy. Do you remember I mentioned metaplasia? Hypertrophy of the muscle, because it is like always irritating. That part is going to increase in size. That is how you are going to see the uterus. The uterus is going to grow in size, but it's not because it is gaining some nutrients or no. It's because it's getting irritated. It's getting inflamed. And that inflammation is what we don't want. That inflammation, we don't want it. And also, if you look at it, it's causing chronic inflammation, neurogenesis, angiogenesis. Do you know angiogenesis? The tissues begin to form their own types of blood supply, which helps them to continually grow. They are going to continually grow. The stroma and the gland of the endometrial tissue is going to continually grow. They tend to form their own angiogenesis. They tend to form their own blood supply. So in this instance, the blood supply is going to be created by themselves. They are going to grow by themselves. It's like you have your own electrical power. You supply when you want, you turn on the heater when you want, you turn on everything you want to turn on just to make sure that you are comfortable. And that is what it happens to adenomyosis patients. That is what happens to adenomyosis patients. There is an alteration in uterine contractility. Oh, guys, you understand these things. Now, how will you know that you have adenomyosis? How will you know? Let's get into this one so that before you even get yourself to the hospital, you know that, oh, I might be at risk of this, or I'm not at risk. No, so if you look at it carefully, there is progressive secondary dysmenorrhea. Do you know dysmenorrhea? Dysmenorrhea. There is going to be that irregularities in your menstrual cycle. Don't forget, the endometrial tissue is supposed to shed off. Now, there's no endometrial tissue. What is there? Myometrium. Because there is trauma to the endometrial tissue, which has deposited into the myometrium. And so what is going to happen? The myometrium is the one supposed to shed off. The myometrium doesn't shed off. It doesn't. It doesn't shed off. It's the endometrial lining that sheds off. So you are going to have different experiences, different encounters. This month you are bleeding. The next month you bleed one day. The following day you don't. The third day you don't bleed. And all these things are challenges a lot of women are facing. So there is progressive secondary dysmenorrhea, which is classical worsening over time. Over the period of time, you realize that, okay, this month I bled for just one day. The following month, you bled for 2 days. The third month, you don't bleed at all. You are not pregnant. You know that you've not had any affair with anybody. So you are not pregnant. But then you progress to the fourth month. No menses again. The fifth month, there is one drop. Then it changes your whole mentality, your whole idea about whether there could be something wrong. Yes, there is something wrong. Or there is nothing wrong. You need to go to the hospital and get yourself checked. There is also heavy menstrual bleeding, and this we call it menorrhagia. Listen carefully. The reason why you are going to have excessive menstrual bleeding is because, do you remember I told you that this same estrogen that is feeding the endometrial tissues, so there's going to be angiogenesis. It means the endometrial tissues have also recoiled. They've produced themselves, or they have reproduced, and they are causing what we call recreation. They are procreating. Let me say that. They are procreating. Is just like making babies. They also begin to make babies. And when they make the babies, they begin to spread. They spread. They spread. They spread. The whole uterus can get engulfed by adenomyosis tissues, the stroma and the glands. And so, whilst your egg, after the fallopian tube, is producing what? Estrogen, or causing you to menstruate, the other part of your body, that I mean to say, the endometrial, the tissues, the adenomyosis tissues, they will also be secreting. They will also be secreting. So you may bleed extensively. You may bleed and be changing your pad like 5 times in a day, 6 times in a day. I think people are really enjoying their life. They are not power tapping. They are not doing anything. No one is sharing a like. No one is subscribing. No one is even sharing the things that excite us. We don't do that, please. Let's make sure some people also benefit from this. The good side of it is that it's live here as well. So if you are there, you can also come there. You get the full video. It will be on there. So heavy menstruation, it often clots and prolonged menses. Instead of having the regular 5 days, 7 days, there are people who will be going extended version. They may be experiencing 8 days, 9 days, 10 days of bleeding. That is 2 weeks. And let me show you. When this happens, how will you ovulate? Come with me. Come with me. How are you going to ovulate? Even if you've gone 10 days, Do you know that you've eaten some part of your ovulation period, of your free period? And so during this time, if you are with your man and you want to actually do something, you cannot do unless you use a condom. And even with the condom, you should know that whilst you are bleeding, you cannot do it, because what did I tell you guys earlier on when we were treating endometriosis? I told you that do not, even if you will, please do not. I won't advise you to have sex whilst you are bleeding, because you will be causing the first stage of even endometriosis and adenomyosis. You are inoculating, you are putting it there. You yourself, you are pushing the tissues into the myometrium, which we don't want you to do that. We wouldn't want you to do that. So be very careful. How are you going to, you are menstruating for 10 days, 8 days, 9 days. Now, during this period, don't forget that the first day of, I'm going to come back to teach you guys on ovulation, when to actually do it if you want to have a baby. Okay, this year, guys, back to back. On those who count their ovulation dates after they've menstruated, I beg, what you are calculating is very, very unsafe periods that are very useless. You calculate unsafe periods that are useless. It doesn't really have egg in them. Okay? It doesn't really have egg to fertilize the ovum. So what you need to do is that, yes, someone is asking really, yes. What you need to do is that the first day of your menses, I'm not going to change the topic. I'm just saying that in line with heavy menstruation and prolonged menses. So you count from the first day you see, oh, I'm menstruating. That day you mark it down, because don't forget, you are either a 28 days, let me not even use 28 day cycle, from 28 to 32 day cycle. Most people, you can add the plus or minus 1 and 2. Imagine on the 14th day, most people are 28 day cycle, which means that if you divide it into 2, it's going to be 14 days. On the 14th day, you are ovulating. But if you want to get pregnant, you have to make sure that on the 12th day, 13th and 14th, 15 and 16, how many days have I mentioned? About 5 days. You have to be actively destroying matters. You have to be having the intercourse more often. From 12, 13, 14, because on the 14th, we expect you to get the ovaries. Okay, the secretion. You're welcome, Nana. We expect you to ovulate during this time. Okay, we expect you to ovulate on the 14th day. Now, on the 12th, don't forget that the sperms remain in the at the tip of the cervix. Maximum about 3 days, about 72 hours. So when you secrete, when the man releases the sperm, what is going to happen? When he releases it, it has the luxury of staying there for 72 hours. This 72 hours, if you did it on the 12th, on the 13th, what is it? 24 hours. On the 14th, which we expect you to ovulate, what is it? 48 hours. Which means that at 48 hours, it can catch it like this. Bam! The eggs will come and then it will catch it. That's why I said stay there, remain from the 12th, be very active. On the 12th, on the 13th, on the 14th. And on the 15th, on the 16th, which means that you can do it on the 13th. Latest by on the 15th, sperm is getting vanished from the system. Right? By then, it would, the eggs would have been able to capture the sperm, and then it will carry it all the way up into the fallopian tube, and then ovulation will proceed. Imagine you are bleeding for 10 days, 8 days, 9 days, instead of 5 days, 7 days, 6 days. What is going to happen is going to shorten the duration of your ovulation. So sometimes when you are calculating from day 1 of your menses, you may forget, because on day 8th, day 9th, day 10th, you might even be bleeding, and as a result of adenomyosis, because you are bleeding, you still count it as part of your menses and even forget to know that on day 14th is your ovulation. Oh, Amma says she doesn't get she doesn't get any notification when we come on live. I don't know, Amma. I don't know. I'm sorry about that. That's why I said subscribe to. You see, you can come on the tube. I have the full video. I've done, when I started streaming as well. So the full video is there. Okay. The full video is there. The full video is there. You can get the full thing and watch. But it's unfortunate you are the one experiencing that. Okay. So imagine 10 days, you forget. Oh, she said, and today's topic is mine. So you will get the full video on the tube. Okay. You get the full video on the tube. You get a full video on the tube. Okay. So look at it. Because of the duration of your menses, because of the duration of the menses, you had forgotten that, this was the time he was supposed to meet me, which means we have to postpone it for another month. Thank you. Someone is giving me more fans. They said I'm doing a really good job. Thank you. It means you have to wait. Let's postpone this pregnancy for another month. You know that I also mentioned that the age from 30 to 50, and let's say you are 40, another month, you don't have months. You are using all the tacticalities in order to get pregnant, but because of adenomyosis, you are not getting the real, duration, which is disturbing. We wouldn't like that. So there is that effect as well. There's also chronic pelvic pain. Do you remember endometriosis? I said there is chronic pelvic pain. You have sex, there is pain. You go to toilet, there is pain. You are menstruating, there is pain. There is constant repetitive. Let me use that word. I love it. Repetitive pain that you are having on daily basis. Last time I was telling you guys that there are some people, before when they are menstruating, sometimes they have to even open their legs and start doing this. They will sleep on hot water bottles at their back. Their sides will be different forms of hot water bottle, and they'll be doing this because there is constant pain. Sometimes they can't even go to work. There are a lot of people, they don't go to work when they are menstruating, especially the first 24 hours, first 48 hours. They don't go to work. And it's because there is adenomyosis, there is endometriosis that is causing some of these severe pains. It's serious. It's very serious. There is deep dyspareunia, and this is very frustrating. Let me tell you. You are having an affair, you are having intercourse with your partner. He penetrates you from the opening of the vagina, the tip, all the way to, let's say you are not very, very long. Okay? Let's say you are from here to, let's say, here. Which means that from here, the cervix, the tip of the cervix begins. Please bear with me. The tip of the cervix begins. Which means that from the gray part, we have the uterus. Okay, the cervix begins all the way here, gets here, and then we have the uterus. The uterus is where the baby goes to sleep. Deep dyspareunia is this. Understand? I said the VV, okay? From the opening, from your skin here, Okay, from here, the length is like this, which means that if you have a partner who is long like this, please pay attention. If you have a partner who is long up to like this, your partner is from here to here, what is going to happen is, under normal circumstance, your VV should be able to accommodate whatever size it is. The VV should be able to accommodate whatever size it is. But the problem is, when you have adenomyosis, the adenomyosis constantly, they deposit on the uterus. What is the opening of the uterus? What is the door? The main door for the uterus is the cervix. Which means that it deposits from the uterus all the way to where? The tip of the cervix. Immediately he enters. He touches this part, just this part. Look, the pain you are going to experience, my dear, you feel excruciating pain. It's so painful that you can't proceed with the sex. It gets to a point you are like, can we just stop? Can we just stop? No matter the amount of lubrication you are using, at this point, you are not dry. It's just that you want to do it, but because of adenomyosis, endometriosis, you are in severe pains. Immediately the manhood touches up to this part. The pain you experience is too much. You can't handle it. When are you going to enjoy this lovely thing? When are you going to enjoy this sweet thing? Because you have gotten to that stage, so you know that it's sweet. You know it will taste good. It tastes something. It's awesome. It's an experience. But immediately he penetrates you up to this part, you can't. And you know, when you are in the mood, you want to penetrate everything. You want to put your whole body into it. So he will also want to hit hard, because sometimes you are like, you are not going hard. When he's tired, you are also saying you are not going hard. Can you do it harder? Can you do it harder? Can you do it harder? So on the day you are feeling the pain, when he's also coming harder, you'll be like, no, stop it. Stop it. And that is the point where the man will be sleeping facing this way. The woman will also be sleeping facing the other way. I hope I'm teaching you something. I know bad boys and girls, they are in one corner. They are saying that, hey, doctor, you're a bad boy. I'm not. I'm teaching you the medicine behind it. Deep dyspareunia is one of the most painful things any woman can experience. You are there. The down part is lubricated. You are enjoying the thing. You are in the mood. He's giving you hickeys all over. How can you get hickeys? Go to work. People will see that you've gotten hickeys. Then you didn't actually enjoy the thing. Hey, you'll be depressed. Your stress level will increase to a different level. So these are some of the things, deep dyspareunia. And there is one thing we call subfertility. You may get pregnant, but it's really difficult. You tend to lose, like, miscarriages, and then all of a sudden it comes, pregnancy is continuing. You know that thing, right? It's like on and it's off. It's like on and it's off. You have to be extra careful when you begin to see things like this. You need to be extra careful. Okay, some of the signs when you go to the hospital, your doctors may perceive that the uterus is symmetrical, enlarged. It means that both sides of the uterus is enlarged. I told you earlier on that because you have punched me, the tissue here that is inside is causing irritation. So what will happen to the uterus? The uterus begins to what? Hypertrophy, expand, adapt. In this case, it's swollen. Okay, and that is going to lead to subfertility, increased risk of miscarriages. Okay, and often it coexists. That's what I was telling you earlier when I started. It coexists with conditions such as endometriosis. It also coexists with things like uterine fibroids. So if you have fibroids, please make sure you are checking yourself adequately. There are some investigations that we do. Okay, there are some investigations that we do. When I'm done, I'm going to give room for questions. There are some investigations that we do. That's diagnosis is often suspected clinically and supported by imaging. What imaging? We will get there. So what the doctors usually do is that they are going to take a full history. They are going to examine your pelvis area. Okay, your obstetrics and gynecologists, they will examine your pelvic area. They are going to request for some blood tests because it will lead you to bleed more. Sometimes you don't even see your periods adequately or well, so they need to request for things like full blood count, check your blood levels, assess whether you have anemia. Sometimes you don't have anemia. What you have is actually there is no iron stores. I know a lot of people in recent times have been asking about ferritin. That is your iron stores. If the iron stores is actually low, it may be telling us that you have a severe type of anemia, which means you are producing, but it's not actually having what the body or the liver is storing adequately. So they have to check for that. They will also check if you are pregnant. They have to check all these things before they can proceed with whatever therapy they want to give you. So pregnancy test, if appropriate, they have to also check if there are any risk of STI. Okay, because infections may mimic some of these signs. Okay, so they'll check for STI or endometrial sampling. That one, they take biopsy tissues. Okay, a little bit, and then take it to the lab to check what is actually embedded in this uterine wall. Okay, so that is that. And then they do some imaging tests as well. They may request for transvaginal ultrasound scan. They may request for an MRI scan if they are not seeing anything but still suspect that there may be a possibility of adenomyosis or endometriosis. They may request for an MRI scan. But the definitive one is doing histopathology. That's the biopsy I mentioned earlier. Now, with the management, most of it, there is no specific management. So let's do it like this. You are in pain. We'll give you something for pain. It is hormone fed, or it depends on hormones. So what do? We give you something for the hormones, right? But the surgical, the surgical intervention they can be doing, okay, is what we call the adenomyomectomy. They go in and check where the endometrial tissues are deposited, and they will tend to take them out. Have you seen fibroid myomectomy done before? They go into the uterus, open it, and start cutting areas where there is fibroid nodule. They take it out. That's a similar way. But in order to treat it completely, if you know you have been able to give birth to all your children, you are done. You gave birth to one, you are okay. You give birth to 2, 3, 4, you are okay. You don't want to give birth again. The definitive one is to take the uterus out. What is the benefit? When you take the uterus out, it's going to relieve you of adenomyosis, endometriosis, uterine fibroids. It's going to prevent endometrial cancer, some form of cervical cancer if the cervix is also removed or the eggs are also removed. Have done it not long ago. Great. Oh, we have evidence here. Let's talk about some of the complications, and then we can close the live streaming. All right. So when you go to the complications, it may be causing series of anemia. All right. Series of anemia. Sometimes preterm birth. When you go to the, how do we call it? When you go to the obstetrics part, I did mine last year. Oh, guys, I've got a lot of people in the comment section on TikTok. They are telling me they've had the experiences before. So I'll be going there to also answer some questions, right? Yeah. Okay, so look at it. When it comes to the reproductive part, subfertility or infertility, that is one. There is obstetric complications that includes preterm birth. Preterm preterm birth, small increased risk of malpresentation. It means the baby's head, instead of it bearing down, the baby's head might be up. That's what we call breech presentation and all that. There may also be progression and treatment related. That is, there is uterine enlargement. We've talked about that already, so I won't go into it. Hypoestrogenic, because I told you it relies on estrogen for its growth. Now, in this case, we need to stop the estrogen. I told you about the hormonal treatment, right? So we need to stop the estrogen from producing. What is that going to do? It's going to put you in preterm menopause. Yes. Or how do we call it? It's going to put you into a menopausal state that you are not even at. It's not your time to be termed menopause, but we need to put you in menopausal state to kill most of the cells, so that we can kill most or majority of the cells. I hope this makes sense. If you find this good, or you find this very important information good to you, kindly subscribe to the channel. Stay with us. We are going to bring you more of similar videos. Thank you.